And all right, good afternoon, everyone. Jeff and Howard are both away, and looks like we may have a small group here, but David's going to start, and then I've got a few cases I can share. So I'm going to make David the presenter here. All right.
Okay, I hope people can see a chest radiograph. And this is from a couple of months ago. This person had had a liver transplant and then had some symptoms that resulted in a chest radiograph. And we see this massive upper mediastinal and right hilar lymphadenopathy. So just a ton of stuff up there that was not there previously. And on CT, we see there's this extensive lymphadenopathy, has a very low attenuation in the center. And so sort to see that, one of the considerations would be, could this be mycobacterial infection? Could this be tuberculosis or an atypical mycobacterial infection? In the AIDS days, we used to see low attenuation lymphadenopathy in HIV patients who had Mycobacterium avium infection. It could be in the chest and abdomen. So lots of low attenuation lymphadenopathy. However, you can also see this with lymphoma. And this turns out to be a T cell, an NK cell, T cell lymphoma. And it was a PTLD. So this is the most extensive lymphadenopathy I think I've ever seen in the setting of PTLD. So really an aggressive lymphoma here. The person is put on chemotherapy, and the current radiograph shows substantial decrease in the lymphadenopathy here. So this was an extensive lymphoma. I've never seen this much lymphadenopathy before from PTLD. Is this familiar to you, Travis? Have you seen
That much? No. Did they adjust the immunosuppression as well as putting them on chemo?
That's right. I think they tried to ramp down, but they put the fellow on frank lymphoma therapy. So this was, I think, too small to mess around with.
Wow. Yeah.
As is frequently the case with lymphoma, there's accompanying pleural effusion. When you get a lot of mediastinal lymphadenopathy, you get pleural effusion, probably just because the lymphatics are being obstructed by the central lymphadenopathy. It doesn't reflect that there is malignancy in the pleural space itself. So really a remarkable lymphoma presentation of PTLD.
Sorry, what was their transplant?
I think it was a liver transplant.
Okay.
I need to verify that, but when I glanced at the notes yesterday, it was liver, I thought.
Wow.
Okay, so I'm used to seeing a few lung nodules, sometimes more than one in the setting of PTLD. I'm not used to seeing such massive lymphadenopathy. Now, I might have another case later on. You can give me a few minutes.
I can show a few, and then if you get something else ready,
okay,
we'll go back to you. All right. All right. So let's see. Waiting to see if my database screen. There it is. Should show up now. This is many of these are vascular cases today, and this is one that happened to show up recently. This patient is just getting routine surveillance. I don't remember what their malignancy is, but they, as you can see on a prior study, they have a big subcarinal node there. And I don't know if it was reassessing that node or just that my colleague happened to see this, but this was the follow-up study, again, on an outpatient. And you can see that node is there, but right in front of it, you can see, on this non-con, this is probably, if not the best, one of the best examples of pulmonary embolism on a non-contrast CT that I've ever seen. I mean, you could see it, the individual emboli going into even lobar, maybe even segmental arteries in the right lower lobe here. This patient was asymptomatic. They couldn't get contrast because they had an anaphylactic allergy, or they weren't going to pre-medicate after this finding. They did do a lower extremity Doppler, and the patient did have DVT in their lower extremities, so they were going to get anticoagulated, but their right heart wasn't dilated, and it's just this is just one of those incidental findings that was pretty impressive. And I was going down to the heart. You could see they're probably a little anemic, maybe there you can see the septum there, so that might help bring out the non-con PE, but this is something we occasionally see and should be, can be looked for in the right setting. And then this is the, let's make sure this is the right one. Yeah, this is the first one, right? And then this is a patient where the pulmonary embolism is not the diagnostic dilemma. And I don't remember this patient's history of why they came in with massive bilateral pulmonary emboli, but you can see that they do have them. And they've even got a little bit of slow flow and smoke to go along with that, and a bunch of, some mixing in the left side and in the aorta, as there's not much contrast that's made it across. But this patient does have some signs of elevated right-sided pressures. And, as I remind my residents and fellows, especially in this setting, always, look for a PFO. And, here we not only get the PFO, but you can see the clot in transit as it crosses the PFO and then goes towards if I can window this better, towards the roof of the left atrium right here. So it's typical, direction of the PFO to go from inferiorly in the right atrium, superiorly in the left atrium. And there was one question of whether or not this was just flow artifact across the interatrial septum, but that wouldn't make much sense because it's going right to left where the densest contrast is. So this just looks like we happen to catch that clot. And this patient had not had stroke symptoms. And the question is, what do you do with this? We do a lot of mechanical thrombectomy and whatever this new vacuum assisted device is for sucking out clots. I don't know what they do in the left side. And this patient actually had other issues as well. They had a GI bleed. So, it was a sticky situation, but I can NPR this really quick here too. But again, I would say we probably catch one of these every couple of years crossing the interatrial septum like this. And you can see it, as it kind of shoots up right there towards the left side.
Wow.
Yeah.
So, we saw one case of this a few years ago, and we claimed it was like in flagrante delicto or something like that, caught in the act. It was actually published. But the fact that we catch them as often as we do suggests they must hang there for a while, right? I mean, it wasn't as if this
Right.
thing was in transit for a few seconds, but it must have been hanging there maybe for hours or something. You were able to get image of it. So
yeah, it's just essentially stuck there.
right.
Or maybe, and I guess you just hope that the whole thing doesn't throw off, or if you don't get a showering of emboli to systemic circulation. But obviously, patients with PEs do present with systemic emboli, paradoxical emboli, and usually we don't catch this, but this is what that is in motion.
Mm-hmm.
All right, this one. So this is a patient who, I'll just show you, they have an AICD, as you can see, and they've got fairly large and poorly functioning left ventricle. And this CT was being done as part of pre-op planning for a ventricular assist device placement. This is a reduced sternotomy. They've had a prior sternotomy for, I think that, they've had at least a Lima graft and other things. But this is the first CT they've had here, and first CT they'd had in a while. And, this was discovered right here in the right middle lobe. And, I saw this a few days later after the PET scan had already been done. But, the pulmonologist came to ask me what I thought, if this was accessible via bronch or what they should do with it, because this was called, spiculated lesion, likely a lung cancer. And I will tell you, I think even on, when I saw this, even on lung windows, you can get a clue to what this diagnosis is. And there's one thing that can be spiculated like this that we occasionally encounter that's not cancer. What do you think, David?
I don't know.
Because I think because when I look at it, I think the attenuation is close enough. It's lower than some of the soft tissue like muscle. And then when you look at it on the soft tissue windows, now you can see that the fat is pretty clear in there.
Mm-hmm.
So, and this was the only spot too, but certainly looks like lipoid pneumonia. And having the discussion with the pulmonologist, they hadn't seen the patient yet. They were just going to see him. So they went and talked to him, and they couldn't get any history of the usual suspects like excessive use of Vicks VapoRub or mineral oils or any sort of other oil. But long story short, when they went to do the VAD, they did a right middle lobectomy just because they were in there, even though we had thought maybe they were going to be more conservative and just follow it with imaging. And it did turn out to be lipoid pneumonia. So we don't know the culprit, but it's one of those things that does look spiculated. But even sometimes on lung windows, you can get a sense that it looks fatty, kind of fatty. And I think the Paxwood monitors show it better than this. But yeah, so
location for aspiration, it seems to be a little more anterior.
Yeah.
Than expected. So.
Yeah, I know, but and I know if Howard were on here, he would mention the rare cases of endogenous of lipoid pneumonia or lipogenosis.
Right.
And if he was on amiodarone at some point, I don't know, but probably there's something that he aspirated. Maybe he slept on his right side because of his heart failure, and that's how they got there. I don't know.
Could be.
All right. Well, this one, the radiograph is, not a dilemma here. You could see this is a patient in their 40s who came in, and they'd had chronic cough to the point where they were having coughing episodes where it was basically inducing vomiting. And so they got the radiograph, and the easiest thing to see is this huge mass along the right side of the mediastinum and obscuring the right heart border and occupying much of the right hemithorax. I think this was a good observation by one of my colleagues here. You can see it on the lateral, and you can also see it anterior on the PA view that there's some right paratracheal involvement as well. So they went to CT, and I think this is one of those ones where, when things get bigger, so big, it's hard to tell where they actually arise from. And, I read this and was looking, and I thought one of the most helpful clues was the fact that it looked like the SVC was being splayed outward here. So my guess was that this was going to be arising from the anterior mediastinum. There's a lot of, vascularity in this thing. It's pretty necrotic or heterogeneous at least. So I was thinking maybe this was going to be some huge thymic neoplasm. Of course, sarcomas are always in the differential. And then I know David has shown at least one case of a medial solitary fibrous tumor. I don't think it was this big, David, but there's certainly pleura along here, if you remember that case.
Mm-hmm.
So what do you think?
What sort of attenuation are you getting out of it? There's no real fat there, is there?
No, this is just some fluid, probably 30, 40. I don't, maybe less. Let's see. If I do a ROI in this area, a mean of 20, just under, but certainly no fat. Yeah, and no like bone or anything else to suggest a big teratoma.
I mean, I guess fibrous tumor has to be high on the list, but I don't understand the splaying of those mediastinal vessels because I've not seen them arise that deep in the mediastinum.
Yeah, and that's exactly what we thought. And they've done a biopsy. They have not taken this out, but the biopsy was positive for STAT6, which means this is a fibrous tumor.
Got it.
And it was only like 3 mitotic figures per field. So, not clearly of the malignant variety. And I think you've said in the past that often the malignant ones are associated with pleural effusions, which this is not. But, arguably the best case scenario for this young lady. So
I think the fact that she'd had symptoms for a long time and that this thing is so big is another indication that it's not aggressive malignancy. It must have been growing slowly for, a decade or something.
Yeah, and I was still just trying to find, there's a ton of vessels that are arising from like thymic. I think these are all like thymic vessels right here. Some of them even from internal mammary that feed this thing. I didn't see any good feeders from the lung. I mean, maybe this portion, like maybe they'll find a stalk when they go in there. This arises from the visceral pleura. But yeah, we did. Yeah, same thought process we had. It was the splaying of the SVC that really, and this clearly looks like it's in the mediastinum here. And that's
Yes,
what got us thinking this was arising from rather than invading into the mediastinum. But the
yeah,
bigger these things get, the harder it is to tell where they come from.
right.
All right. Now this is just kind of a quickie, but a good example. And this is a young patient in their 30s who has this opacity in the right lower hemithorax. They have acute symptoms. I think we'd call this pneumonia, maybe a small little parapneumonic effusion, assuming they have cough and fever or respiratory symptoms. For whatever reason, they went to CT, and I think that the person interpreting this, they see the effusion, they see the reduced area of enhancement, and just chalk this up to pneumonia with a parapneumonic effusion. But of course, this is a nice segment of hypoenhancing lung, and it has that kind of central ground glass and the peripheral rind, really good for an infarct. And sure enough, here's the PE right there, occluding the what is that? The anterior basal segment, I guess, or the lateral. Yeah, no, that's anterior. There's lateral. There's posterior, because you've got some collapse of
Yes.
both posterior and lateral. So yeah, so I think it's just occasionally we see these overlooked. There was no PE anywhere else, but not a pneumonia. This is an infarct.
It's really nice to have the enhancing lung next to
Mm-hmm.
it, just where the vascular occlusion is and where it isn't.
Yep.
Good contrast. Yeah.
Yeah, to have the atelectatic lung right next to it, and as or hopefully everybody on here knows that parasympathetic effusions are common in these. They're sterile exudates. Like I've seen, like around a third of patients with PE and infarct will have small effusions. So not a parapneumonic effusion. All right, and then this last one, also vascular, but let's see if I make sure I can get this in the right order. This is a patient who had this in the lateral segment of the right middle lobe, and it's a little adenocarcinoma. It had been growing. And so they went in and did a right middle lobectomy. And here you can see is the immediate post-op radiograph where there's a chest tube, there's a tiny little pneumo, a little bit of volume loss there. And then I don't know, let's see what the time frame was. This is the next day. Now you can see there's this opacity brewing in this area, and patient's doing okay. And you can see on the lateral view, it corresponds anteriorly to where the right middle lobe was. And then they take out the chest tube, and that opacity is still there. And it's kind of got that, it almost looks like it's, over distended portion of lung here. It doesn't look like it's collapsed. And so, there was some concern of torsion, even though, the right middle lobe still looks like where it is, and the right upper lobe, is where it should be. And there's, could it be something involving the segment, or was there just bleeding next to the lung? And this is kind of interesting because still not exactly sure how this happened, but this certainly looks like that infarct in the last case. And somehow they took out the tumor, but they thought they had done a complete right middle lobectomy, but left a portion of the right middle lobe in. And so this is all remnant right middle lobe that's been devascularized, both from the artery and the vein. But when they were doing the thoracoscopic surgery, it just some of that lung just got left behind. So it looks like what a torsed lung or what a thrombos, like a venous thrombus, would look like, or any other infarct. It's just very boggy and expanded. So they went in, took out the rest of it. She was fine, but it was just curious because her anatomy, on the pre-op, wasn't some crazy variant. She had, I can look here and show you. I mean, she had just looked like normal pulmonary venous anatomy. Her right middle lobe pulmonary vein coming off separately, but no big deal there. So I don't know. I think when they're working in tight spaces, doing thoracoscopic approach, sometimes maybe it's it's hard to identify all the planes. But
So this was a right middle lobe adenocarcinoma to start with. I thought I heard you say that it was a right lower lobe, but it is a right
No,
middle lobe, right?
yep,
Affected?
right middle lobe, lateral segment.
Okay. And they thought they took out the whole middle lobe, but
Right.
they really ended up taking out the segment.
Yeah, I guess
So
so.
do you think that the remnant torsed?
No, I think the remnant. I think they ligated the entirety of the vascular supply to the right middle lobe, but I think they only ended up getting like taking out the rest of it. I think. Let me show you on the axial because that's what we were trying to look at that, but I didn't like the airway is. Let's see here what the best window is to look at this. Oops. Now, if you follow, so right upper lobe bronchus here, and then the right middle lobe bronchus is totally cut off right there. It's ligated. You can see the suture line.
Mm-hmm.
And then same thing with the pulmonary vein. You know, the pulmonary vein, that middle lobe pulmonary vein is ligated right there. And you know, and then the pulmonary artery looks like they got it right here.
Okay.
So, yeah. So, and there's a big staple line right here. You can see, so everything was stapled across, and it's not, you know, the full right upper lobe is still intact here, you know, anterior segment, posterior segment. So it's not like they accidentally ligated a portion of that. It's just strange.
Okay. And it's
But
really overdistended there probably by the venous infarction. It's
right, the
probably getting
venous congestion, yeah.
some perfusion's getting through, but nothing can get out. So yeah, wow.
But yeah, I mean, this is non-enhancing lung. There's no atelectasis to contrast like that pulmonary embolism and infarct case. But you know,
Mm-hmm.
whenever you see lung like this, you have to think about some sort of venous or infarct or venous congestion. So,
Got it.
all right, you have another one ready, David, or
I think I do here. If you give me just 1
sure.
second here. Okay.
All right, making you presenter again.
So this case came through yesterday. It's I think, a woman in her 30s, I think. She has a history of coarctation, and
I'm
she'd
not
never
seeing
had
screen
any.
yet. Oh, there we go. Okay, there.
Is it visible?
Yep.
So I'm showing you a scout view from a CT scan. This woman has a history, has a known coarctation, but she's never had any intervention. And the only imaging study we have is yesterday's CT scan. So normal heart size, not that abnormal a contour to aorta. There's a little bulge above the aortic arch up here, which corresponds to a slightly dilated subclavian artery, which goes along with coarctation. Rib notching, I don't know, maybe there's a little notch here on underneath the surface of this rib. Be nice to have a formal chest radiograph. I might be able to reconstruct from the CT and generate a fake chest radiograph. One of the important things about notching is, first of all, we don't see it very often anymore because most people get interventions early enough. But often the ribs, the lower part of the rib sort of thins out and tapers, and you can't see a distinct cortex on the lower surface of the rib. So a lot of people overinterpret that and they call that notching. But a true notch actually has a sclerotic boundary, so you'll actually see thickening of the cortex and you'll see a curved indentation in the lower surface of the rib. So this qualifies. It's this area here. Maybe that's notching. It definitely has intact cortical line that you can see, and it seems to be a little concave. So actually fairly modest. It's possible to overinterpret this as the 3 sign, but the 3 sign is supposed to be the narrowing underneath the aortic arch and then postnodic dilation below that. So the waist of a 3 should be down here below the top of the aortic arch. It shouldn't be above, as in this case, where the top bulge here is really subclavian artery. So this ends up being actually a very substantial coarctation. So I can't show you the 3Ds because they've got the patient's name on them, but you can see this dilated subclavian artery above here, and this is part of the collateral pathway, and then the aorta basically almost disappears for a short segment, and then resumes normal caliber going down as we go down here. So here it's very narrow. There are lots of collateral vessels going on, and then the poststenotic slightly dilated component below the narrowing point. And on the sagittal view, we see that this coarctation is actually right at the takeoff of the left subclavian. As a matter of fact, I think you could argue that there's poststenotic dilation because there is some narrowing at the origin of this subclavian. So the typical location is distal to that left subclavian. This one's really right at the subclavian. You can see that it's a very severe narrowing of the aorta. And then there's some atresia of the arching part of the aorta. So it's not just this point of narrowing, but there is the whole arch is atretic. So with coarctation, because the arch often tends to be hypoplastic, as in this case, that's why you don't get a very dramatic 3 sign with most cases of coart. If you do see a dramatic 3 sign, it's probably not a coart, it's probably a pseudocoart. In that case, the bulging upper component is the actual arch, and the waist of it is what occurs at the normal level of the typical arch, of the regular arch, and then you have poststenotic dilation below that. So very dramatic, high degree of stenosis here caused by this coart with atresia of the arch, and not a real 3 sign, which goes again with coarctation. Not much of a 3 is fine for coart. Person did not have a bicuspid aortic valve. There was some ambiguity on the echo about the condition of the aortic valve, but we saw 3 leaflets, and we don't know whether 3 leaflets are opening normally. There was no thickening and no calcification to suggest that there was a dysfunction there. So a very dramatic case of coarctation, untreated, no intervention in this woman, I think in her 30s or 40s.
Wow. And it looks like there were some chest wall collaterals. And do you think some of that is because of the location near the subclavian? Like, are some of those on the right side more than the left side? Like even outside, like lateral thoracic and.
Right. Yeah. And then look here, you can see that there's some dilation of the internal thoracic artery, which gives rise to those anterior intercostals. Let's go back to cross sections here and let's look at these chest wall collaterals. So lots of collaterals here all over the chest wall, and a lot of stuff snaking in here to feed these posterior intercostals and then get blood.
Yeah, and anteriorly, like the
descending aorta here. So we've got vessels all over the place. And this person is entitled to have rib notching. A very good question for residents is so when you see that rib notching and you know it's a dilated intercostal vessel, which direction is the blood flowing in that? So this brings out a lot of the hemodynamics. Most people assume that the blood is going out from the descending aorta. That's the normal pathway. But in this situation where the descending aorta is not being properly fed, the blood flow in the posterior intercostals, the cause of the rib notching, is actually retrograde. It's picking up blood from the internal mammary or internal thoracic. It's going in anterior intercostals, which connect with posterior intercostals, is forcing blood retrograde into descending aorta. But you can see the snaky collaterals here in the paraspinal region. And then here's that very high degree of stenosis of the aorta. It's really almost lost in this area.
Really impressive.
Okay. Well, that's all I've got assembled this week, Travis.
Thanks. Anybody else? All right. Well, thanks, David. Thanks, everybody, and see you next week.
Thanks, Travis. Thanks for filling in.
All right. Take care.
See you. Bye-bye.